Sharon, take it away.
All right. So, hello, everybody. Welcome to the 10th virtual shadowing session. Today's topic is going to be diversity in medicine. And our guest speaker today is Dr. Ava Pierce. She is an emergency medicine physician who works at Parkland, one of the busiest EDs in all of America. She's also an associate professor, associate chair of diversity and inclusion. And that is our information on the bottom right of the slide if you want to reach out to virtual shadowing. And so we can go to the next slide.
Next slide, please, Ava. Hello, next slide, Ava. Can you click
Yeah,
forward?
I'm trying to get you there. Don't know what's going on.
There we go.
Cool. And so this is the virtual shadowing working group. We have Reagan, we have me, Cheyenne, Taylor, Alana, Rachel, Anirudh, Mariam, and we have Dr. Fowler, and then we have Dr. Marchetti, who is not here tonight because he is working. And then we can go to the next slide, please. I'll turn it over to Dr. Fowler.
Y'all, it's my absolute pleasure to once again welcome a very, very special individual that I've known for many years in the busiest emergency department in the United States, which means in the world. Ava Pierce is an outstanding doctor, and she is one of the most sympathetic, warm, engaging individuals that I have ever known. She is one of those people that I can truly say that if I get ill, I want her to be in the ER when I'm there because she has good sense. She's so experienced. She knows the right end of the stethoscope, and she just loves people and manages the emergency department very well. Next slide. Before we finish our final introductions of Dr. Pierce, I do want to let you know that next week we'll be spotlighting pediatrics and pediatric emergency medicine with Dr. Pam Okeda, who is actually with us this evening. August 18th, we'll be doing a specialty spotlight on acute trauma care from Dr. Williams from the University of Chicago. And then on August 25th, joining us will be Dr. Angela Gardner, who is the past president of the American College of Emergency Physicians and is professor of emergency medicine and quality medicine at UT Southwestern there in Dallas, which will be an outstanding show. You can join us on Zoom and YouTube Live at 7 o'clock Central Standard Time. And once again, these are our three contacts. Ava, next slide, please. And so it is my distinct pleasure to welcome one of the great thinkers in our field, who is a recognized national chair in diversity for the Society for Academic Emergency Medicine and is associate professor of diversity and inclusion in the Department of Emergency Medicine at UT Southwestern. Dr. Pierce, Ava, my friend, take it away. Welcome, and we're so glad to have you.
Dr. Fowler, thank you for that warm welcome.
And also, as we progress through this session, please feel free to enter your questions into the chat, and we will pick and choose which questions we're able to and try to answer them as best as we can. So.
Okay, so I have no disclosures. And so we'll start a little bit talking about my journey into medicine and emergency medicine. So I guess, when I was in high school, I loved science. I loved helping people, and kind of as those two came together, I thought about what I would want to do for a career. And so I shadowed some physicians from the community and really realized that taking care of patients for the rest of my life was what I wanted to do. I went to undergrad at LSU in Shreveport, then medical school at LSU in Shreveport Medical Center. Then I journeyed to Atlanta, Georgia, where I did my residency at Emory University School of Medicine and spent the majority of my time training at Grady that you'll see on the screen, another one of the busiest county hospitals in the country. And after that, I came to UT Southwestern, where I spent the majority of my time working in the emergency department at the Parkland Health and Hospital systems, but also teaching clinically in the medical school and at UT Southwestern. So I'm going to talk a little bit today about why diversity matters. I've spent the last several years with the niche in diversity and inclusion, trying to advance diversity in medicine for the US. So let's think about diversity. I like this slide because it shows an example of what diversity really is to me. So we like to say it's different individuals valuing each other regardless of skin, intellect, talent, or years. So diversity is not just one thing. So if you think about the US Census, in 2020, the projections are here for 2012. And when you look at 2060, the country is going to go from where the majority is going to become a minority. So why is diversity important to our organizations? 15% of gender diverse companies are more likely to outperform those who are not. Ethnically diverse companies are 35% more likely to outperform those who are not. So what are some other advantages for our organizations? Diversity has a positive impact with many key aspects of organizational performance. You get improved customer orientation, improved employee satisfaction, and improved decision-making. What about the learners? So underrepresented in medicine students, those who are LGBTQ, are more likely to be involved in practice, research, education, scholarship, service, and mentorship activities aligned with their identity. There are also some accrediting bodies that say we need to look at diversity and inclusion to increase patient satisfaction, improve patient outcomes. So diversity in medical education improves the learning and cross-cultural competencies for all doctors. In this paper, in American Crisis, the Lack of Black Men in Medicine, it's noted that increased physician diversity is often associated with greater access to care for patients with low incomes, racial and ethnic minorities, non-English speaking patients, and those with Medicaid. A diverse physician workforce leads to improved quality patient care. So we want to think about equality versus equity. If you look at the picture on the screen with the three individuals all being given the same thing, this is not true equity, this is equality. So when we consider in medicine, you actually need to give patients what they need. So the first person was tall enough without a box. He didn't need the box. The second person needed 2 boxes. And the third person, the person in the wheelchair, a box was not going to help him to have equity. He needed the ramp. So ultimately, as we look at you becoming physicians, I want you to think about helping your patients get equity. This report by the Institute of Medicine says that domains of quality that you should provide safe care, effective care, care that's patient-centered, timely, efficient, and equitable. Healthy People 2020 says care that's not equitable leads to health disparities. So looking at that Institute of Medicine report again, the racial gap in America's health remains and in some areas continues to widen. The Civil Rights Act of 1964 says that no person should be excluded in the United States due to race, color, or national origin. And we look at the national class standards. They are made to advance health equity, improve quality, and help eliminate health disparities. One of the principal standards says that we are to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. We need to consider the social determinants of health and how they affect our patients. Patients are really affected by economic stability, neighborhood and physical environment, their education. You have to look at the health literacy of the patient, food, hunger, community and social context, the social support system in the community, any discrimination that's present. And within the healthcare system, what kind of health coverage do they have? Is there provider availability? So really, if you look at these health outcomes, the mortality, the morbidity, the life expectancy, healthcare expenditures, health status are all impacted by these social determinants of health. There have been noted disparities in healthcare and pain management, and not just adults, but in children and different minority groups. This manuscript on health outcomes in US children with abdominal pain in major emergency departments associated with race and socioeconomic status showed that based on race and socioeconomic status, There's a disparity of health outcomes in patients seen with abdominal pain. There were differences in appendicitis with perforation, differences in length of stay, and differences in the time until surgery. There are also disparities in healthcare and trauma. You'll see that there's a disproportionate number of MVC deaths in minority patients. In this study of racial disparities in the treatment of acute overdose in the emergency department, over 3,000 patients with acute overdose were reviewed. Black and Hispanic patients in this study were less likely to receive any antidote when presenting to the ED for an acute drug overdose. So what are some next steps to decrease healthcare disparities? We need to improve the awareness of healthcare disparities among the general public, key stakeholders, healthcare providers. We need to produce high-quality research on disparities. We need legal, regulatory, and policy recommendations, health system interventions, and education on health disparities and health equity. So we got gains in health disparities after the Affordable Care Act was passed. 16.4 million uninsured people gained insurance at that time. 4.2 million Hispanic patients gained insurance. 2.3 million African Americans gained insurance. So what are some other diversity outcomes? Diversity can help organizations improve both patient quality care and financial results. A return on investments in diversity can be maximized when guided deliberately by existing evidence.
Ava, this is Ray. This is magnificent. You know, there's so much information on your slides. I almost wish you could just slow a little bit. This is so good. You know, the whole issue of implicit bias, you know, I'm an old white guy from Georgia that grew up in the desegregated, initially segregated and then desegregated era in Georgia. And when we've heard discussions about the fact that we grow with implicit bias, but I just wanted to say there's so much detail on these slides. Thank you so much for this.
You know, one thing I recommend people do, we won't touch in it on this presentation because there's a lot here and there's not enough time, but I recommend that everyone go and take the Harvard Implicit Association test. It's free, you can do that online, and I think you'll learn a lot about yourself. You'll learn about some of your implicit or unconscious biases that you have. You know, and everyone has bias. That's one thing we want people to think about. So if you take that test and all of a sudden you go, oh my goodness, I can't believe this about myself, know that it exists for everyone. And learning more about yourself will help you be a better person, a better friend, a better colleague, and a better physician one day. So I do recommend that you spend some time with the implicit association test. There are ones there for several different things, race, gender, and really learning about your bias, like I said, will help you in the future. I had one colleague who took the test and he works with me in the area of diversity and inclusion. And he was shocked that he had a bias for males being the leaders in science and then females like at home being stay at home. And he was like, how could this be? You know, this is an area that I specialize in. But when you think about it, it is an implicit bias. And so knowing that about himself, he said, you know, so now whenever I'm going to hire somebody for a job, I stop and think, do I associate a male with a leader? And if that's the case, I need to be very intentional about considering everyone for this position. And when he thought about it, he felt like his mother was a stay-at-home mom, and that's probably how this happened. So know that, you know, everyone has those biases, and it really helps to learn about it.
You know, I've been working in ER for over 40 years, and the slides that you shared with us a few minutes ago that said that a Black kid who came to that certain emergency department was much more, with an abdominal pain, was much more likely than a white kid to have a ruptured appendix. And I just go, my goodness, you know, these intrinsic biases that we have, what is it in us that doesn't let us do what we're supposed to do, which is to develop an advanced differential diagnosis without regard to race, color, equity, and ethnicity, and so forth. But I was just very struck by that slide, Ava.
And clearly these are all multifactorial. You know, if you don't have insurance, are you going to wait longer to go to the ED? You know, are you going to go to an ED that's busier? Are you going to go to the county hospital, but maybe the wait is longer? And, you know, the critical trauma patient is going to be before you. And so there are multiple factors, but even mitigating those factors, there are definitely differences that have been found. So let's move on to this article on trends in health equity in the US. So this article shows that there's been a lack of progress in health equity during the past 25 years, despite all the changes that have been made. So when we look at reaching for health equity, know that it will reduce health disparities and bring us closer to health equity. So I don't know if we want to stop for mini QA or see if there are any other questions you have.
We have questions pouring into the chat room.
Oh.
One question was, Ava, and well, is implicit bias such that the LGBTQ folks have less of a chance of getting in medical school, do you think?
I don't think that's the case. I think, so I do work with several people around the country, and really right now, I think everyone is moving toward holistic review. And it's not about a number. I think everyone knows that it's not about a number. We want to have good people in medical school, in residencies, that are going to take good care of their patients, people that are committed to whatever their passion is. There are people that want to be surgeons. They love surgery. There are other people that tell me that they've learned from their experience being an LGBTQ person, and they want to go and give back. They want to be a mental health provider who helps adolescent teens work through the issues that they went through being an LGBTQ person. So one of the groups that I work with has developed some educational modules on LGBTQ health. And so really, it's learning about yourself. And I think really learning what your mission and what your goals are. So for me, anyone who's underrepresented, the diversity organizations that I work with help and work on policy to try to improve that. We have an accommodations committee, and we look at furthering the mission and goals of those who need accommodations. So there are several different areas in the area of diversity and inclusion that you have to look at. When we look at gender, we'll see there's some papers that will talk about the leaky pipeline. If you look in academics, as you go along from instructor to assistant professor to associate professor and full professor, we lose people all along the way. And so that's another thing that my group works on. We want to improve diversity and inclusion in the workforce. But as we look at people that are interested in academics and really interested in teaching other physicians, we want to not lose those people along the way. So we really do some work with promotion for underrepresented in medicine physicians.
So, Ava, what about, there was an odd question, or interesting rather, question that just came up that said, so what's the position on medical schools, PA schools, and so forth about applicants who have tattoos and piercings? We've had plenty of residents who've had gorgeous tattoos on their arms, I know. We both can think of several in the recent past. Do you have a position on that?
I do not have any known position on tattoos personally that I've seen documented. Anyone speaking on that one way or another. So I don't know if you have any other experiences, Ray.
It's never come up. It's been interesting to be a man who came into medicine at a very young age in my early 20s. I got into medicine when I was 20. I'm now pushing 70. And to watch how I've changed. One of the questions that just came up, Ava, one of the students just wrote, should we try to fix the bias within ourselves? Is that possible, to fix our own biases, to recognize them and fix them?
So I don't know if you can fix bias, because as we talk about implicit bias, we will say everyone has bias. But what you want to do is recognize what those biases are that you have, because there's conscious bias and there's unconscious bias. So if you have conscious bias, you clearly know it's there. But the implicit or unconscious biases that we're talking about, we want you to learn more, because there are things that you can do to combat them once you know that they exist.
This is just excellent because, especially the the role of being absolutely honest with yourself, because medicine is the opportunity to look into the mind and the heart of other people, to engage with them in a mutual opportunity to improve health, to better the human condition, as we've said now for several months. But we have to fight those biases that would prevent us from doing that. I know one bias: when you're in a busy emergency department and you have a patient comes in the middle of a busy ER where you've got dozens of patients to take care of, and then there's a language barrier. And I don't just mean Spanish, because many of us speak Spanish or we have ready interpreters, but Urdu, Arabic, Somali, and Mandarin Chinese, to name just a few of what we see. And sometimes in your fatigue, when you have to really work to be able to get through the language barrier on a language that's really quite uncommon in an ER, is that an example of bias, Ava?
Yeah, Dr. Fowler, you bring up a great point. There are actually several different articles that show, the times where it may be more likely that you will have problems with your implicit bias are the exact examples of times when we work in the emergency department, when you're very busy, when you're fatigued, when things are out of your control. And that's the environment that we work in every day. But I think, a lot of people will say, treat your patients like your family members. But I try to go to work with that in mind every day. I think about growing up in my community and the care that I would see patients receive or not receive. And I always think about, I want to be the person who goes above and beyond. I want to make sure I'm treating everyone in that emergency department the way I would treat my family, the way I would want to be treated, the way I would want you all to treat Dr. Fowler. Because I really think Dr. Fowler and I have become great friends now. Dr. Okada's on the line. You'll learn that, through emergency medicine, I think we've made friends that are friends for a lifetime. We're not just colleagues, but we're friends. And I think we see ourselves be there together in the best of times and in the worst of times. We sometimes take care of patients who have good outcomes. And, it's such a good feeling to work really hard and have a patient get better. But there are days where we take care of patients and no matter what we do, that patient does not get better. And then those are the hardest days, but we have colleagues that we work together and we're there for one another. And I think this is a time right now with the COVID-19 pandemic that you'll see healthcare workers are really suffering in addition to the patients. It's so hard to talk to colleagues all around the country now. Initially I would say colleagues from New York and New Jersey, but it's really everywhere now in Texas that, the effects on their mental health from seeing people day in and day out just get sicker and sicker and sicker, and young people die. When you talk to people in the community, everyone knows someone that's had COVID-19. Someone would say one day, it's no longer that I'm going to wonder if I know someone who's died. I'm going to say who's died from the virus today. And so it's impacting the mental health of, like I said, not just healthcare providers, but of the community too. You look at the school closures and that's affected our students. When you look at the high school students that were, looking so much forward to graduation last year and maybe didn't have a graduation. But these are things that we have to do for the health of our nation, of our country. So, we have to take care of not just the physical health during this pandemic, but the mental health of our country too.
So Ava, as someone whose COVID test has gone positive, about a month ago, my swab was positive, and then my blood test went positive 2 weeks ago, and I didn't have any symptoms, thank God. I don't know if it was the melatonin and the zinc and the vitamin C and D that I take and the famotidine, but regardless, I've been very, very lucky, and probably most people are asymptomatic in this very strange disease. But as I know, and Brandon's on the line and Pam's on the line with us, all of us co-workers, what toll has this taken on you and your family, the COVID epidemic, moving a little bit away from diversity and inclusion to your own personal fatigue factor, or is it a little harder to come to work now? Or you still got that spring in your step? I mean, how are you?
I think it's harder for all of us. I mean, I think, we've all seen patients, young patients, not survive. and you suspect it's COVID-19, or young patients who are known to have COVID-19 who come in and are very, very sick and don't do well. And I think that has to take a toll on anyone. And then you look at your families. We've all want to keep our families safe. And, Dr. Fowler and I were talking about visiting family the other day. I have elderly parents. And so I've not been able to spend as much time with my parents because of this virus. So I think it's really taken its toll on all of us. I have, all of my friends and I have been doing virtual schooling for our children, which is different. We've realized that some of us, we laugh and it's like, we were not made for this. So it's easier for us to teach medicine than to go back and teach middle school math or algebra 1 or algebra 2. So there have just been a lot of challenges. And I think really also seeing the children suffer is hard also. I was reading one study that talked about the percentage of school students who actually get their mental health care solely from services at the school. So them being out of school, their mental health is worsening, not just from the pandemic, but from the fact that they can't get the services that they would normally get. So when we look at solutions to, taking care of the physical part of it, I think we also have to look at, in the future, putting in policy that will protect people during times, because there will be another pandemic. I think Dr. Fowler and I never would imagine that we'd be living through this, but you want to learn a lesson whenever you go through something to make sure things are better, that the next time something happens.
I was fairly young in my practice in the early 80s when HIV showed up. And it was so weird initially. And then it was in the blood supply. And then there was nothing that could be done. And there was a period where we thought it might kill everybody in the world. And I'm not exaggerating. And then AZT showed up. And then the protease inhibitor showed up. A vaccine has never shown up. And so it was a much more slowly moving pandemic. But, and for all the new upcoming career medical students, PA students, nursing students who are on the line tonight, you will see another epidemic again. And, just stay tuned, because it will happen, especially as human diversity spreads out through animal kingdom diversity around the world, if you read about these things. Well, Ava, I didn't mean to interrupt so much. Why don't you go on to the next half of your talk?
No, because we're going to pivot from that, but I think it's very important to have these conversations. I wish we could all be talking, so I'm glad you all are putting things in the chat. But we just want you to learn a little bit more about medicine, the world we're experiencing, what we're going through, why we love emergency medicine, because it's a calling, it's a special calling. We work with all the specialties in medicine. So, we take care of patients that have strokes, and we work with the neurologists. They come down and we work together, and, we decide on if that patient can get the clot busting medications to help them with the stroke. Is it safe for them to get those medications? Is it not? We take care of very sick trauma patients, and we work with the trauma surgeons during that time. Patients with broken bones, we work with the orthopedics. So for me, the diversity is that we get to do and learn some of everything. We have patients with heart attacks and heart failures. We work with the cardiologists during those times. We have diabetic patients that have complications, diabetic ketoacidosis. We'll call the endocrinologist down, the internal medicine doctors. They'll come and work with us in those times. So for me, emergency medicine is just a specialty where when I mention diversity, I get to take care of everyone, no matter, if they're insured, uninsured. Like we see people, like I said, some of the best of times and the worst of times. We see some of the sickest patients that exist sometimes, and really to be able to help those patients, for us, really makes practicing emergency medicine worth it.
So Ava, how do I get past this thing at a man pushing 70 years old about the fact that if I have patients that won't take care of themselves, they come to the ER when they're falling down because they're drinking themselves to death, or doing heroin, and they're covered with sores, and they're infecting their heart valves. And we've reached out to them time again to give them resources. And somehow we can't keep the bottle out of their mouth and the heroin needle out of their arm. How does that not slow us down a little bit and say, gosh, if you won't take yourself seriously, how can I help you?
And I think the one thing there, Dr. Fowler, is working in multidisciplinary teams. Sometimes as an emergency medicine physician, I'm not always able to reach their patient. But, if the team includes a social worker who can maybe look into what's going on in the home, a psychiatrist that can call the family members, sometimes someone else is able to help us reach that patient. So know that in medicine, you're not alone. Believe in the teamwork and know that, it's really the team that sometimes can really make the difference.
Do you think Medicare for all could somehow make an impact on intrinsic biases so that everybody had full access to all the care they need? That's a political question.
That's a very interesting question, Dr. Fowler. And rather than answer it, I'm just going to say that, I want to take care of all patients. And I think that's the one thing about emergency medicine. When patients show up to us and they have an acute medical condition, I'm able to take care of whoever shows up at my door.
And one of our students just said, "Thank you for being a hero, Ava." So please
Thank
go
you
on.
for Dr. Fowler and Dr. Marchetti for being heroes. All right, I think we'll pivot now into the next part of the talk. And this is a little bit, when we do some of this diversity work, we'll say sometimes that people will have imposter syndrome. So I don't know if people have thought about imposter syndrome, know a lot about imposter syndrome, but as you look at the things you want to do, sometimes you think, am I good enough? And a lot of us think that way. So we just want to run through a few thoughts about imposter syndrome. So have you ever felt like you didn't deserve to be where you are right now? You think if they really knew me, they'd know I don't have the right to be here. One of these days, people will realize I'm a fraud. When you get to medical school, the admission committee must have made a mistake. Was I really supposed to be in this medical school class? So what is imposter syndrome? It's a pervasive feeling of self-doubt, insecurity, despite often overwhelming evidence to the contrary. A persistent fear of being exposed as a fraud. Imposter syndrome refers to an internal experience of believing that you are not as competent as others perceive you to be. Imposter syndrome doesn't discriminate. People of every demographic suffer from feeling like a fraud. Does anyone know who this is? I'll see if anyone can type it in the chat. Some people have forgotten who she is. Some of the younger people don't really know her. Anyone in the chat tell us who this is?
Oh yeah, looks like a couple know.
A couple of people know?
Yeah.
Who is this?
Jodie Foster.
Okay, Jodie Foster. So she said this. She said, winning an Oscar, I thought it was a fluke. It was the same way when I walked on the campus at Yale. I thought everybody would find out and they'd take the Oscar back. They'd come to my house knocking on the door. Excuse me, we meant to give that to someone else. That was going to Meryl Streep. So if you ever feel imposter syndrome, know someone as accomplished as Jodie Foster, who went to Yale, was brilliant, won an Oscar, even at that status thought maybe she didn't deserve it. So when you look at imposter syndrome, there's one part of it that we call status comparicus. So you have some cool accomplishments and accolades under your belt, but you meet someone else who's accomplished more. You start shaking internally about how impressive and important everyone else's accomplishments are. So what are some solutions? Shake it off. The other person is awesome, but so are you. Just because they're awesome, it doesn't mean that you can't be awesome also. Awesome is an infinite resource. No one can be awesome in the unique, authentic way that you can be, only you. Wanting to be anyone other than yourself is a waste of time. Shoulding all over yourself. So saying, I should. You tell yourself, I should do more. I should do more research. I should get on more committees. I should do more volunteer activities. I should do more mission trips. There's not enough on that application for medical school. I need to do more. So what are some solutions here? So the things that you do, I want you to think about, they must pass the why and the who cares test, or you shouldn't do them. You shouldn't do things just to have a number of something or put something on a list. It needs to be what your passion is. So when you say I should do more, ask yourself why? You should do it if the answer is because it resonates with me. I'm passionate about it. It's my career goal. So if the incessant why leads you to something like, because someone else is doing this, so I should do it too, you need to say no to those things in your life. Anytime you have the shoulds, it must pass the why test and the who cares test that we just discussed. So what about ants? So you have a friend that says, hey, that's a really nice outfit. And your answer is, oh no, I have no fashion sense. I'm a hot mess. You have a coworker that says, that was a really insightful comment you made at the meeting. And then you say, I'm only on the committee because they needed a warm body. So these are the ants, automatic negative thoughts. They pop into your head before you even realize they're there. The infestation is insidious and destructive. These little bug-like thoughts eat away at the foundation of your self-confidence. So how do we get rid of these ants? As soon as you get a compliment and hear yourself thinking or saying anything negative, stop in your tracks immediately. Replace your typical reply by saying thank you and accept the compliment. The key to eliminating your infestation is immediate recognition and immediate counteraction. So telepathic delusions, vague goals, and fear. When our confidence feels low, we are afraid to admit what we want. Instead of telling people our goals and dreams, we just try to think them so hard that people will notice our efforts and magically give us what we want. We're scared of reaching for our goals, so we do self-sabotaging behaviors like procrastinating, half doing things. What you think you're doing is protecting yourself from rejection. But what you're actually doing is preventing yourself from reaching your goals. So what are some solutions for this? No one can read your mind. If you want something, it's time to ask. Live your life and do that awesome, amazing thing that is authentically and uniquely you. And what about perfectionism? You dot every I, cross every T, over-prepare and over-rehearse before you will make a comment. You're afraid that if you make one tiny mistake, everyone will realize that you aren't perfect. You're worried they won't think you belong there. And you're worried you don't belong yourself. So what are some solutions here? It's time to stop worrying so much about what other people think. People aren't thinking about us nearly as much as we think they are. So what are they thinking about? They're thinking about themselves. So stop worrying so much about being perfect. Newsflash, you're not perfect, but neither is that awesome person that you're feeling intimidated by. We are all just humans. So what about the feeling of being overwhelmed? Everything you have and do is balanced on the foundation of your self-confidence and self-worth. When the base is rickety from lack of inner support for yourself, from the ants being eaten away at you, it's no wonder you feel wobbly, right? The imposter syndrome keeps us lonely because we are afraid to reach out and make a meaningful connection and confess to our others. But the only way to beat it is to shine a light on it. So some solutions here, reach out. Humans aren't meant to be solitary creatures. Use your support system and speak your truth. 70% of educated and successful people feel this way, and it's very likely that those around you can relate. So know that you're not alone. Even if you're sheltering in place right now, there are ways that you can reach out to your friends. So this is a review on imposter syndrome among physicians in training. So this is an article that you can go and review and just tells you how imposter syndrome can negatively affect those in training. So this is a 3-point exercise for those who recognize that they have imposter traits. We won't do all of this now, but it's just something I want you to think about. So document both positive feedback and your doubts about its authenticity. This exercise will demonstrate for you how you discount the opinions of other people. Examine the messages that you have received about yourself from your family and others. Understanding where your negative self-image comes from can empower you to break free. And then imagine telling your peers and superiors how you have fooled them. And think about how ridiculous this would sound if you really did that. So think about some ways you can combat this imposter syndrome. The truth is, there will always be problems and stressors in life, but you can change how you respond. You are absolutely empowered to do that. Connect with others. Recognize your ants. Keep track of your achievements. practice self-forgiveness, and practice and strengthen your confidence skills. You can also use imposter syndrome to your advantage. Like we like to say, keep a little bit of imposter syndrome in your pocket, because this can help you stay humble. It's a balancing act that exists between imposter syndrome and egomania. Authentic modesty keeps you real. So if you're always thinking I can get better, it actually can push you to get better. We never want it to be to the point that you feel like you're never good enough. So know when you get into medical school, when you get into PA school, when you get into whatever health profession it is that you're looking for, know that your school did not make a mistake. You do not need to be someone perfect. Who you are, your authentic self is enough. And it'll help you make this difference in medicine that we're hoping for you to make. There's this Clance imposter syndrome scale that you can take on your own time. And I'll just kind of flip through this. And after you take this, you can add up your score and it'll tell you about your imposter traits. If your number is low, you're less likely to have imposter traits. But if the number is high, then these imposter syndrome traits are something that you want to be working on. So thanks for sharing this time with me. Those are all the slides I have. And if we have a few other questions or things we want to discuss, we could do that now.
Ava, we've already gotten a lot of feedback of folks saying they really want to take the exam in the chat room. So we will have this recording available so that folks can download it at YouTube and being able to take the exam. When do you realize, or do you even realize, does someone even realize they have the imposter syndrome? Do you know, or what do you think?
I think a lot of people have this, and some people never realized what it was or there was a name to it. But I find a lot of my colleagues and myself, I would say there are a lot of people in medicine that are type A personalities. You always want to do well. You always want to do better. We're working hard. And it's easy to look at the person that's next to you that has 3 or 10 NIH grants and, they've got 30 publications and you have 5. So even at whatever level you're in medicine, you sometimes look at that other person and say, oh, I'm not doing enough. I should be doing more. I should be doing what they are doing. But know that you want to be doing what it is that's your passion. And what you're doing is enough. Whatever your contribution is to medicine, that's what you're going to give. Be passionate about that and work on that to your best.
We're getting literally dozens of people writing in saying, thank you so much. This was an amazing. And also, again, thank you for being such a wonderful hero. Dr. Okeda, it's good to see your smiling face there. Can we let Dr. Okeda off of mute so Reagan, so she can make a comment for us? Reagan, welcome, Pam.
Hi, guys. Thank you so much for inviting me. I can see everybody's smiling faces. So good to see everybody who's interested in healthcare. And I'm excited to be part of your group. I'm going to be available next time to talk about pediatrics, my journey, and what pediatric emergency medicine is all about. So come with questions. And I'm a pediatrician, so you can scribble all over the conversation. I am okay with that.
That's great. So Cheyenne, do you have any questions from the chat room or other questions that we've received? And while he's coming up, Pam, we've already gotten a dozen people saying, I'm going to be a pediatrician. So
yay. I'll put one thing out there. There's one thing I like to tell the students now when we look at cultural competence, cultural humility. For a lot of years, people said, look at the golden rule, treat others the way you want to be treated. But I encourage all of you as you pursue medicine in your careers to look at moving to the platinum rule. Does anyone know what that platinum rule is? See if someone puts that in the chat.
Someone says I do.
Okay.
So far, no.
Okay. So that platinum rule is treat others the way they want to be treated. So when you consider patients' beliefs, values, their culture, you want to incorporate all of that in how you care for patients. And so no longer I talked about, wanting to treat people like they were my family members. But moving beyond that, I want to treat them the way they want to be treated. You know, there are times when we've had patients that wanted to leave the emergency department against medical advice. And maybe one of the residents brought me the paper and said, that person in room whatever wants to leave, can you sign them out? But I stop and say, no, let's go and see what's really at the bottom of this, you know. And maybe it was that patient had a religious belief that they hadn't shared with anyone. Or there was something about their culture that they hadn't shared with us. And by me just stopping and sitting and listening and saying, you know, I understand, I'll do anything I can to, within your beliefs, help you. They were willing to stay in the hospital. So just know that, you know, you really having more cultural humility, cultural sensitivity can really help your patients. So I kind of challenge all of you to, you know, increase your cultural sensitivity to help your patients.
Ava, Oprah wrote, treat people like blood runs through us all. Okay, the other day in the ER, I had a very sick man come in. He happened to be Hispanic and he happened to be my age, which is old. And he was slowly dying of advanced liver disease and cancer. And I got a warning that his vital signs on the monitor were taking a dip and we needed to go in the room real quickly, and we did. And his oxygen level had gone way down. And the resident and I examined him. We could hear no breath sounds at all on one side. And with this guy having advanced cancer in his liver, this spoke to the fact that he had a significant amount of fluid that was built up on that particular side of his lung. One of the members of the team, and this is what my question is, one of the members of the team said, oh, he's all right, he's all right. And for the moment, I found myself irritable. This would happen to not be a physician that said this, and that, in fact, please don't question my exam. This man actually is quite sick, which he was. He had neck vein distension, and in fact, he had a tension hydrothorax. He had such pressure due to the fluid buildup on one side of his lung that it actually was causing shock. But it was distinctly, in my opinion, and I'm entitled to my opinion, an intrinsic bias moment where this other staff person was just sort of assuming that the guy was not really as sick as he seemed to be. And so it seems to me, Ava, what I'm trying to get at is that trying to beat the intrinsic bias thing across the entire team is so important.
No, it's very important, and it just makes me think about one thing, Dr. Fowler, is that gestalt that you can probably tell everyone on this call about. There's sometimes as a physician, when you just have this feeling, you know that this patient is sicker than someone else realizes that they are, and you really have to be an advocate for that patient. And so I guess I always look at it as being a patient advocate, like something is troubling me. There's something going on with this patient that we haven't found. We haven't diagnosed it, but we need to keep working to get to the bottom of it. And you really just have to be that advocate with the rest of the team. Someone else may have bias there and they may say, no, you can discharge that patient, they can go home. But you know that if you ever have that feeling, it's based in your years of experience. Dr. Fowler and I will tell you, we will not send that patient home. And so eventually we may find what was going on, what was wrong, but it's those things that I think I look at as more being a patient advocate, because, you know, people will have bias. There may be some bias within the team, but at some point you will be the leader of that team and you will be responsible for setting the tone for the team. So, you know, when you walk into the ED that day, you know, you want people to know you're here. You know, we're here to take care of patients. We're going to work as a team. And I think if you set that tone, others will kind of fall in line with that tone.
Let's see how many of the students online tonight remember Fowler's first law from 3 months ago. We'll see who comes up with that. But it has to do with starting simple when you examine your patients. Vital signs, the reason they're called vital signs is that these are the signs of life. Someone just wrote it, Mary Matthews, said, always explain a tachycardia. Good for you, Mary Matthew. But in fact, you have to start very simple and very basic. And I think maybe that's one of the key points, is that if you commit yourself to starting at a fundamental level and building your differential diagnosis on that, then maybe you work your way out of intrinsic biases that may come naturally to you.
And I think many of Dr. Fowler's trainees will repeat that, always explain a tachycardia. In their days, Dr. Fowler, we as your colleagues will repeat it also. It's like, think about what Dr. Fowler said. They're about to discharge somebody. Always explain a tachycardia. He's well known for that. But I think it has saved many people. You know, when you look at that heart rate and you're about to send somebody out of the door, what have you missed? We talked about being an advocate for that patient. You know, if you've missed, you may have been missing something that's almost life-threatening. So it's really important. And with COVID and fever, and a lot of people are tachycardic, we'll treat patients and that tachycardia will decrease or go away. But if those abnormal vital signs remain and you have not gotten to the bottom of what's going on, you need to stop and think. What else is in my differential diagnosis? What have I missed? You know, I thought this was just COVID-19. Is this COVID-19 with a pulmonary embolus? You know, I thought this was just dehydration. Is this not just dehydration? Is there something else going on? So explain those unexplained vital signs.
So even moving then beyond, all of us as physicians, as PAs, as nurses, as NPs, are going to make an error. How do we deal with making an error, especially if somebody gets hurt?
That's a good question, Dr. Fowler. I think, you know, so we have and I'll talk about a session that we have so the surgeons will have some sessions called morbidity and mortality. We've kind of changed those continuous quality improvement. And I think one thing is know that there's no way you're not going to make an error in your entire career. People make errors. The one thing in medical education we try to do, I keep talking about that, teamwork is working in a team. So know that as a medical student, you're going to have a resident and an attending there to back you up in the hopes that someone on the team will catch that error. They'll help you with, you know, we talked about you were going to discharge that tachycardic patient. Dr. Fowler is going to say, no, we need to keep that patient here. We need to look at what else is going on. But I think knowing that we're all human, to err is human, is something that you have to consider. And so when those errors happen, we look at the process. And if there's something that we can do so that it doesn't happen the next time, you know, where there's something in the system process that we can change. You know, did that error happen because of a bad handoff? Then we can work on communication and handoff. So I think as long as you learn something from each of those situations, then that's how you move on, because no one is perfect.
You mentioned handoff, Ava. What is the most dangerous time for a patient in the emergency department?
It's definitely handoff at the end of the shift. So, you know, we work shift work. I'm sure you've heard us talk about. And so I'm a nocturnist. So right now I work just night shifts. And so at the end of your shift, you know, you finish what you're doing and you hand that patient off to the next person. And it's very important that you give all the details, as much information as you can, because when you realize I've taken care of that person for the last 8 hours, I know what they look like when they came in the ED. I know what they look like now. And it's really interesting. We'll take care of somebody that looks very, very sick. Maybe for, say, somebody that has congestive heart failure. They come in, they're breathing really fast, they're sweaty. You know, we get them on the monitor. We start medications that decrease their blood pressure, open their lungs up, they're breathing better. And sometimes the team will come down to admit them and go, wow, they look fine. Why am I even putting this patient in the hospital? But I know what they look like when they roll through the door. And so that's very important. And Dr. Fowler is leaving the emergency department. He makes sure that I know, you know, this person looked really, really bad when they came. Do not let them go home. And that's very important, because there are times where at that handoff, something's not communicated to the next person. You walk into the room, something changes. The patient wants to go home, you know, and you think, well, they look okay now. They really want to go home. But, you know, Dr. Fowler knows what they look like when he saw them 8 hours ago. And he knew when he walked in the door that that patient was not to go home. And if ever I come onto a shift and Dr. Fowler checks out and he says that patient needs to stay, that patient's going to stay in the hospital. And there may be someone that has a different opinion, because it's the art of medicine, right? There's no, I mean, everything is not done the same way. So, you know, I will say, you know, Dr. Fowler took care of that patient for 8 hours. I know what they look like now, but he knew what they looked like 8 hours ago. This person needs to stay in the hospital. They're a high risk to deteriorate or decompensate. So I just think making sure those things happen in handoff, that communication, that we really understand what needs to happen and why is very important.
So Ava, changing subjects, you're a wife and a mother, and you work overnight in the emergency department. Are you crazy? Do you like getting out of the house? Where'd you meet your husband? How in the world do you manage all this? How many kids do you have?
So I have 2 teenagers, and I think all of EM physicians are a little bit crazy. So, but we're the greatest group of crazy people you ever want to meet, I would say. So I met my husband at a church function, believe it or not. There was this retreat for several different churches with singles ministries, and we went there. And it's funny, it was the last day of the retreat. We were in a class, and I was about to walk out, and he said something to me, and my friends and I looked over, and we kind of went about our way. And then he said something else, and I was like, well, who is this guy that keeps talking to me? I don't know him. And he said something else, and then it's kind of funny. He gave me a business card. I laugh about this. So I was like, And so it's like he does something outside of medicine, because it's interesting to have friends outside of medicine sometimes. And so, we communicated, and several years later, here we are still married. And so we have 2 teenagers, a 16-year-old daughter, a 17-year-old son, who are entering 11th and 12th grade this year. So my journey to being a nocturnist has been interesting, because I did not work just nights when I started. One of my close friends early in my career was a nocturnist, and I said the same thing to her. That is really odd. Why do you work only nights? And she said, it works for my family. And that's been the one thing about the flexibility in emergency medicine. Her husband was an attorney, and she said, I work nights. She said, when I get home, I put the kids off to go to school, then I go to sleep, and then I wake up before they come home from school. And then I'm there with my family. We have a regular evening, and they're off to bed, and then I go to work. And she said, I'm not missing anything. And so I did not at that point, I was not married. I didn't have any children, and I didn't foresee myself being a nocturnist, even though I've always been a night owl. But as things progressed, at one point when my kids were younger, I worked just the early morning shift and the night shift, because they would be in daycare in between. And it's things progressed where they were no longer at the age for after school care. Some of my friends hired somebody who picked their kids up from school, drive them around after school, do homework with them. But for me, that was a quality time that I really wanted to have with my family. So I was like, I'll try this all night shift and see how it works. And it's really worked out for me. So, I'm there most mornings before they go to school. Sometimes I don't end my night shift on time and they're off at school before I leave. But, I would pick them up in the afternoon. We talk about how things went. It's really quality time that I think I would have missed out on if someone else was driving them around. The flexibility of being an EM physician, I laugh, is like I went to every field trip that they had in elementary school. I was always there. And one of my friends was an internist, and she couldn't be there. She was like, I can't close my office down. So her daughter would hang out with me and my daughter. But, for me, it means everything in the world that I was able to be there for every field trip. I was there at the skating ring. I was there in the park. I was there on this field trip. I wasn't the room mom. I even have one of my colleagues who was an EM physician that was the room mom. I didn't go that far, but I think you'll find as EM physicians, we're just a special group of people. We want to be there for our patients. We want to be there for our families. And I like to say, when I go to work, I work really, really hard. But when we leave, we play really, really hard. We enjoy doing the things that we do outside of work. So really having that shift work has been really beneficial for my family. And I do a lot of administrative things now that are 9 to 5, but I can kind of work my schedule around that. So, my mother was an educator, so she was always there for me because she worked at the elementary school where I went to school, and I wanted to be that same mother for my children. And I think emergency medicine has enabled that for me.
So one of the questions that popped up during that wonderful talk you just gave was, so for me as a white guy, is it gender bias for me to ask you how it is you manage your schedule as a woman, as an African-American, and as a mother? Do I show gender bias from even asking that question?
And Dr. Farrell, I guess I know you so well that I wouldn't even think that you were if you asked me that question. But no, I think that's something that as a woman that we have to consider. A few of us were talking recently about the changes during COVID. And a lot of my male colleagues talked about writing 5 manuscripts during this time where some of the specialists were not able to work clinically. They had more free time. And then a lot of the mothers talked about, still we felt like we did more of the care for our children. So not only were we going to work and coming home, but then when we got home, for some reason, keeping up with virtual online school was up to us. And so a lot of my colleagues and some of the women physicians will say they've become less productive during COVID. So it's something I think is real, and you have to think about. There are definitely differences due to gender. We look at there's differences in promotion due to gender. And one of the Academy for Women and Academic Emergency Medicine group has done some studies on this. We talked about that leaky pipeline. So, as you look along your academic career, maybe you're not going to get promoted as fast as everyone else, but maybe you want to work part-time for some point while your children are growing. That's important to you. So you have to realize kind of what those priorities are, and hopefully work within a system that can help with those things. So for me, no one can say everyone has had it all, but emergency medicine has afforded me the opportunity to be able to work hard, be there for my family, and still accomplish the things in my career that I wanted to accomplish.
Ava, changing subjects again, how do we recruit more physicians of color to our medical school? I know we get some applicants, but the African Americans especially are very sought after by American colleges and universities in America. And you said something to me the other day about reaching into the kids' lives earlier and earlier. I'm trying to put this correctly. Could you explain that a little bit more about what you said? Because I thought that really struck a chord with me.
Now, so some of what the diversity group that I work with does is we call it increasing the pipeline. So a lot of us like to say, you can't be what you don't see. So when we go into an elementary school or a middle school and say, I'm a physician, I'm a medical student, sometimes someone in that room will have an aha moment. They never thought about that I could actually do this, or I could be a physician, or I could be a physician assistant, I could be a nurse, I could be someone in the healthcare field, because they'd never seen anyone that looked like them that was doing this. So really increasing the pipeline is one thing that I think is very important. Just letting women, those who are underrepresented in medicine, know that, there is a place here for you. You can be successful in this field, and that we want you to consider it. Consider something that maybe you never considered before.
I think it's wonderful. Pam, please speak up. Cheyenne or Rachel, if you have any questions written down for the group, can you speak up, please?
Yeah, sure. So actually, I had a personal question regarding your emergency medicine schedule. So how has it been adjusting your sleep schedule kind of throughout the years? I know that when you first start out as an EM physician, the hours are not as flexible. I believe that it kind of gives more priority to seniority. But how has that been for you?
So, most people around the country love someone to be a nocturnist because a lot of people would rather not work nights. So if you find that group of people who wants to work nights, people are very happy to hire you. Like I said, because it gives other people who might not want to work nights a break. So some of my colleagues work more weekends as you look at people with families, and not to say that it's a perfect schedule, but what works for your lifestyle is what works, and it kind of works for me. At some point, I was like, I won't do this forever. I'll figure out where. When I made that switch to nights initially, it was a little difficult, but I think you have to figure out when you sleep, how you sleep. A lot of us as EM physicians we'll have like dark curtains in our bedroom or a blacked out room where you make that room as dark as possible. And inadvertently, there's somebody like doing construction at some point, and you figure out then when you get some earplugs and put those in. So I think you just have to kind of figure out the adjustments and figure out what works for you.
Cool. Interesting. Okay. So then there's a lot of questions asked by all the other students as well. So I can kind of read off some of those as well. So I guess this one kind of goes.
Okay. So I guess I actually did an accelerated 6-year program, and those have kind of gone by the wayside. And when I looked at that, it was a tough program because we started undergrad right out of high school. We did 2 years of undergrad going every summer, and then we went into medical school. And there are a few of the people that were in the program with me that did not make it because it took a certain level of maturity. And you can look back and say that program's definitely not for everyone because you lose some of the things in undergrad that you won't get back. So I would never be the person that would have a 15-year-old go to college. But for me, cutting those 2 years off, I think was okay. But because I felt like I was mature enough, there are some people that could not handle that. So I think you just have to know yourself. And then after those 2 years of undergrad, we started medical school and then went through 4 years of normal medical school, just like anyone else. And from there, like I said, I went to Atlanta to do an emergency medicine residency. Spent most of that time working at Grady Memorial Hospital, like I said, one of the busiest county hospitals in the country. We also spent some time at community hospitals, the hospital that used to be called Crawford Long. I think it's now called Emory Midtown.
Right.
The Children's Hospital there, Eggleston, and the University Hospital at Emory University, where you would see a different set of patients, like patients with transplants that might not be at the county hospital, which is similar to what we see in our patient population now. We work mostly some of us work at Parkland, which is a county hospital where we will see, it's a level 1 trauma center where you'll see significant trauma patients. And then there's the University Hospital that has sometimes some specialized transplants that don't happen at the county hospital. So you really get to see more of those patients that have heart transplants and kidney transplants, sometimes in different centers based on what happens at different hospitals.
Interesting. Well, that's very interesting. Thank you.
And I guess when I was trying to decide on my specialty, maybe some people, how did you decide? I think when I was looking, I liked a little bit of everything. And that's how I ended up in emergency medicine. I like taking care of children. I like taking care of adults. I like taking care of teens. I like taking care of older adults. And I was trying to decide, what am I going to do? At one point, I thought I might do OBGYN. I thought I liked delivering babies, but I was like, that's not what I want to do for the entire rest of my life. And so finally, I did an emergency medicine rotation. And I had that, this is for me. And in my medical school, it was not a required rotation. So I actually decided later in the decision-making process than some. But I think you'll have that aha moment when you think about what your personality is. Do you feel like you want that continuity of care where you're seeing patients in an office day after day? That's not emergency medicine, even though we have some people that come in quite a bit. And it feels like they're my primary patients. But we really take care of the undifferentiated patient. That's what you see in emergency medicine. The patient comes in with chest pain. You need to figure out what's going on. Is it a heart attack? Is it pneumonia? Right now, is it COVID-19? They have a fever. Their heart rate is fast. And that could be, is that a bacterial pneumonia? Is that a viral pneumonia like COVID-19? Is that a pulmonary embolus in the lungs? So you really take that patient that comes to you with this group of symptoms and you have no idea what might be going on with them. And you have to figure out what they have, treat it along the way, and then triage where they're going to go. The sick trauma patient you're going to take care of with the trauma team. Do they have a head injury? Do they have chest, thoracic, abdominal injuries? Are they able to breathe on their own? Do they have like a bleeding in the brain? Do you need to help them breathe, put them on a ventilator? There's several things that you have to think about. And I think for us, just getting to take care of all those different type of patients is what we really, really enjoy.
So Ava, you strike me as somebody sort of mid-career. I'm way out there on the autumn of my career. I know, though, I would like to work 10 more years. I would hope I can be strong enough to do that. Ava, are you burned out? Would you define yourself as someone who's burned out? And if yes, why? If no, why not?
I'm going to say I'm not burned out because, I think, some of it's self-care, some of it's resilience. And for me, I think it's more than, I'm going to say it's my parents is the reason that I'm not burned out. And so I look at the contributions and the sacrifices that my parents made. My father was the first Black mayor of the small hometown that I grew up in. my mother was the first Black person to graduate with a master's from the university that she went to. And she would, I would have conversations with them about the things that they did and how they made a difference and why they did what they did. And, the times when my mother would discuss like getting her master's and enrolling in this university and people saying, well, I don't know if that's a good idea for you to go there because there's never been a Black person to graduate from with a master's from there. Or they're not going to let you, to pass this class, you have to be able to go to this place, and they're probably not going to let you go there. But, for them, the answer was, well, why not? So I feel like I'm standing on the shoulders of those giants, my parents, and I look at the changes that they made and the difference that they made. And for me, it's because of those things, I feel like I'm not going to get burned out. And I just keep working hard. And I know that I'm grounded, and for me, in a faith that I'm working hard to make things better for people. And there will be some tough times. Like, no one's perfect. No one's not going to go through things. And clearly, there are times where you get tired. But I think times like that, I look to my colleagues. I'll call Dr. Fowler, Dr. Okada. You look to those who are going through what you're going through. And I think that's where you find your strength. And that's where I find mine.
How much longer are you going to do this? And are you going to stay academic?
You want to answer that, Dr. Okada? How long are you?
No, I don't know.
She doesn't know. None of us know. I don't know. I haven't thought about retiring just yet.
I worked half of a career. I've been around a long time, 43 years of clinical practice. So I worked a full generation in the private sector in Atlanta, my hometown, where I'm sitting at the moment, actually. And another half of my career at Southwestern. We've talked about this on previous sessions. And I have to say, I really like the friendships. I adore the friendships that I've made there at the university. It was so different being in private practice because I was sort of the only person who would come and go, and I didn't have these close collegial relationships like I've gotten at Parkland and at the university. Excuse me. So I personally prefer being around people that I just love. I trust. They love me. We understand each other. I fully understand that if I did something stupid, Ava Pierce would come up and say, "Ray, let's talk." And Pam Okader would kick my butt, and because we understand that we're trying to do the right thing. But this is a tough, imperfect business that we're in, which is trying to develop a differential diagnosis on the signs and symptoms of every age group, of every gender, of every ethnicity at all hours, 24 hours a day, 7 days a week, in every language. It's a real challenge. But this is the world of medicine, and this is the world that the still 1,200 kids that are still online with us here got to know that if you're going to do this, this is not something that you play at. This is something very, very serious, but it's very rewarding. That was a long-winded answer to that. I'm not going to quit either.
You know what, Dr. Fowler, somebody asked about academics, so I think we can maybe all give our viewpoints on that. Dr. Fowler and I both worked in community medicine for a while, so I'll share that when I started, I did not imagine that I would be an academic emergency medicine physician. And I started and actually took a community job for a couple of years. And so I enjoyed having that time after residency that I felt like some of us will say you need to get your own feet under you. You feel like you need to leave academics and take care of patients by yourself because all that time you've had an attending to ask questions, to help, and you just want to be out there on your own. And at some point, though, I started to miss it. I miss the teaching aspect of it, even though, there were some paramedic students there that I were able to teach. There were some nursing students that I was able to teach. I missed the entirety of medical students and the residents and conferences and the complete teaching aspect of it. And maybe it's that both my parents started out as educators and they instilled that in me, but there was something about it that I really, really missed. And I had the opportunity to go back in academics, and I think I've never looked back. In the time that I was here, I worked with the medical student clerkship helping medical students who wanted to pursue emergency medicine think about those careers. Looking at, how many places around the country do you need to interview at for residency, and, looking at where you go for residency. And it's just been, I think it's been the thing that has helped me not burn out, having colleagues that I work with, having some, administrative duties in addition to just working clinically, where I feel like we're really making a difference.
And Pam, I would welcome your comment about that, please, about, why you're in an academic program. Have you always been? Do you plan to stay, and so forth?
Yes, I've always been in academics. And somebody asked, what does that actually mean? And it means that we get to take care of patients, we get to teach, we get to train up the next generation of physicians, and we get to do research. And so you get to do it all. And that's why I chose academic emergency medicine and pediatrics. And I'll be able to touch on that next week. The other thing is I chose academics and specifically a large university because I wanted to have a big family. Okay. I wanted to have 12 kids. I wanted it all. Right. I see Miss Martinez smiling. Well, you know what? I wanted to have 12. My husband pooped out on me. I got 5 kids, but I was able to do pediatrics, a fellowship, and do research and work part-time until my kids were old enough to be able to, go back to working full-time. So there was flexibility.
This is wonderful. Rachel, Cheyenne, any more questions from the group?
Yes.
You have a lot.
You have a lot. So I can go over a couple of those as well. So the next question one of the students had asked is, as a woman and a person of color, how do you, Dr. Pierce, deal with discrimination from other doctors or patients?
And that's a great question. So for me, there are several things that you have to look at. So when someone is discriminating against the students that I work with, we definitely want to stand up for that student. So there are times where I walk in the room with a student and a patient might say they don't want this person to see them. We have to let them know that, we do not believe in discrimination. Anyone that's there with us in that room is trained well and are there to take care of them. There are times where, from modesty, I'll have a female patient that really wants to be seen by a female for religious and cultural reasons. And things that are for religious and cultural reasons, we try to understand, but something that's pure discrimination, we're not going to be able to accept that. As physicians, it's on us to take care of everyone. So you do have to think about that. You took an oath to take care of all patients, not just nice patients. And you will take care of patients that are not nice. And I try to kind of walk in those areas saying that, sometimes there's something wrong that maybe you can change the situation. They had a bad experience, that you can be the person that makes a difference. And there are some people that are just discriminatory, and I'm not going to let them discriminate against our team. Everyone that's there is trained well, and they're able to take care of you, and you're here because you need our help. And sometimes you're able to communicate with patients and they'll understand and they'll let you take care of them. There are times patients actually really want to leave against medical advice because they don't want that person to take care of them. And there's no one else to take care of them. I had a colleague that had a patient that didn't want to be treated by a Black physician. And they said, it's clearly not the first time that it ever happened, but the person had like fractures of both legs. The person couldn't walk. And the colleague said, I wonder, they can't get up and walk out of my emergency department. I don't think they even thought about that. And they just explained to them that, there's an entire team of physicians here to take care of you. You're in one of the best hospitals in the country, and we're going to take good care of you. And the person finally said, okay. But said they were thinking somewhere in the back of their mind, you are like very critically ill and you're showing this discriminatory behavior, but you can't even get out of my emergency department and get up and walk out of here. So I think you just realize that there will be some discrimination and that you need to stand up for your team and try to do your best to take care of the patients.
Yes, no, that's very well put.
And so one of the other common questions that we've gotten, so this person actually said, I think one of the reasons why we are seeing so few underrepresented people in medicine is due to the many barriers that underrepresented minorities face, just even in applying to medical schools. Do you believe this is a big contributing factor? And what can be done to remedy this to make medicine more equitable? And how can we, as aspiring doctors, reduce our internal bias to treat everyone with equity?
So that's multifactorial, but I think one of the things that I've done through the organizations that I work with, or to try to work on things at the policy level. So like I said, a lot of these accrediting bodies right now are realizing the importance of diversity and inclusion and how increasing diversity in the workforce is actually going to help us decrease health disparities. As you talk about patients' concordance, patients sometimes will be more likely to adhere to their treatments if their physician looks like them, understands their beliefs. So I think really looking at holistic review and implementing programs that help us to realize, it's not just about a score on a test, but there's some groups I work with that do test prep. But really knowing it's the whole person. So really, we look at holistic review. It's not about just what your score is. It's about who you are as a person, what your leadership traits are, why you want to care for patients, and really what your journey has been in life. All those things have to be factored in.
Right. And luckily, it seems like holistic review is becoming more mainstream. So that's a good thing as well. And so I guess the next question would be, this is a little bit, I guess, off topic, but what's the difference between practicing medicine in a private hospital versus a public hospital? I don't know if that's an experience that anyone here has had.
That's a great question. I
would take that one, Ray.
I worked 20 years for the Hospital Corporation of America. And I actually, Pam will smile at this, I worked 8 years before EMTALA was passed. And for the students, that's the Emergency Medical Treatment and Active Labor Act. I worked for a private hospital as a young kid in his late 20s, and we didn't have to see the patients. There is now a law that it requires it. If you bill Medicare, you have to see the patients, or the feds will come in and close your hospital. And so I most certainly worked in a private hospital for the first half of my career. And you're basically, I'm going to use the term moving the meat because that is said a lot. Please forgive that it actually is intended to be rude. It has to do with moving a lot of patients through a healthcare setting for the purpose of making money. That's very much what private healthcare is about, though not exclusively by any means. You can most certainly be a humanitarian, very dedicated to the human condition, working in the private sector. Indeed, you can be involved in all sorts of areas, plastic surgery and so forth, and be very close and connected to your patients. And so what about a public hospital, Ava? You having cut your teeth at Grady.
So, that's the one thing about working in the emergency department. I can take care of whoever walks through the door with an acute illness. There are some hospitals that are for profit rather than not for profit, that's not the case. I have colleagues around the country that they've been asked to screen to see if the patient has an acute medical condition. And if they don't, and that hospital doesn't take their insurance, someone may offer that patient to not be seen there after their medical screening exam has been done. And so I always felt like I wanted to choose a hospital where I could take care of whoever walked through the door.
What about you, Pam? About working for a university-based public hospital. Children's is not exactly a public hospital per se, but it's the Central Children's Hospital in Dallas.
Yeah, so it is a public or not-for-profit hospital that takes care of all children that comes. I've never worked in a private hospital. However, I've worked in an academic situation, and then our Plano hospital is a community situation. And so there's that dichotomy between a tertiary care hospital that takes care of transplant children, very complex medical conditions, And then our community hospital, where we take care of more bread and butter emergency medicine, like broken arms and lacerations and asthma. And then anything complex that comes, we will transfer back to our main university hospital in Dallas. So that's the dichotomy that I worked in. But you know what? Before I did emergency medicine, I was a general pediatrician in the community. And I did that for about 4 months. And so that was a different time in my life that I thought I wanted to just do general pediatrics. But emergency medicine was too exciting, and I needed to go back to school to be able to be an ER
Well,
doctor.
here in my hometown, 5 miles from where I'm sitting, I built my own urgent care center back in 1982, and I ran it for 20 years. And as you know, what urgent care center is, it's cash on the barrelhead. We would see everybody, but we would also transfer the things out. They were certainly beyond the scope of the urgent care center. And we did staff it with board certified emergency physicians, this being 40 years ago, so a different mindset and a different culture in those days. Ladies and gentlemen, it's been an hour and a half already. Cheyenne or Rachel, do you have one or two more burning questions? And then maybe we'll let these folks have the remainder of the evening to themselves.
Maybe since somebody asked about this pediatric emergency medicine versus emergency medicine, we can take that one and end with that. So I trained in emergency medicine. And so my residency was a 3-year residency. There are some that are 4 years. And at the end of that specialty, you can do a subspecialty. And there are several different subspecialties in emergency medicine. And we may have talked about some of these before, I'm not sure, but there's toxicology. So some people have trained in acute poisoning and overdose. Pediatric emergency medicine is one of those. And so you can train in pediatric emergency medicine either after an emergency medicine residency or after a pediatric residency. And I'll ask Dr. Okada to talk about that training of pediatric emergency medicine.
So you guys are stealing my thunder because I get to talk about it next week.
Oh, I'm sorry.
Pediatrics, pediatric emergency medicine, you can first do 3 years of pediatrics or 3 years of emergency medicine, and then do a fellowship in pediatric emergency medicine. So it's another 3 years of training in critical care and EM. So it's just six years. So it's a longer run, but you specialize in kids, and I only take care of children under 18.
And so in our emergency department, we take care of mostly adults, but we also take care of some children. So because we are a burn center in the hospital that we work in, we take care of children with critical burns. Being a trauma center, we'll take care of children with head injuries at a certain age and up. And so other specialties, there's ultrasound is a specialty within emergency medicine. I have colleagues that train to do special ultrasound. And, when they're taking care of patients, they can come in and do like an ultrasound of the heart and help us figure out a lot of things, an ultrasound of the abdomen, looking for fluid in a trauma patient if a trauma patient is bleeding. There is administrative fellowships after emergency medicine if you're somebody that feels like you want to be a medical director. So there's just a lot of different paths. There are medical education fellowships after emergency medicine for people that realize they want to work within medical education after emergency medicine. So there are just a lot of options for most careers in medicine.
Ava, I want to thank you so much for what a wonderful session. Pam, thank you for being here. It was extra special to have your sweet smiling face. Ava, you're just a doll. You're a delight. Thank you for bringing your experience and your expertise to us. We're putting up on the screen now, Reagan, is the Quest Base exam. I'll have that up on the website momentarily. Y'all will have until Friday at midnight to take your exam. I would like everybody to do a big shout out on chat to Dr. Pierce to say thank you for giving your time and your love and your dedication to your specialty. The thank yous are pouring in, Ava. So on behalf of the working group, Dr. Morchetti is also out there somewhere lurking. We just want to say thank you. This is our 10th session. I want to remind you about the GoFundMe. We're asking everybody to give $1. It's costing us about $5,000 a year to put all this on. The Zoom account alone is about $1,300. So if you can afford $1, please do that. You'll find it on the website. And we just want to thank you very much. Thank you for being there. As long as you keep coming, we'll do these sessions. We look forward to Dr. Okeda next week to share her love and passion for pediatrics and pediatric emergency medicine. And so with that, everyone, we wish you a good evening and a good night. Thank you for coming.
Thank you all, and we look forward to your bright futures in medicine.